Good morning, everyone. Myself Satyarupa, this is Geraldine Jacob and Jasmine. We are here to present a case on breast. Mrs. Kasturi, 68-year-old female who is a homemaker from Thuthukudi, came with a chief complaint of lump in the left breast for past 2 years. Patient was asymptomatic 2 years back. Then she noticed a lump in her left breast, which is painless, insidious in onset, initially smaller in size, which increases gradually in past 3 months to attain current size. She also noticed recent retraction of nipple in the left side for past 2 months. No history of ulceration of nipple or nipple discharge, no history of trauma, no history of fever, no history of weight loss and appetite, no history of bone pain and bony tenderness. No history of breathlessness, no history of cough with hemoptysis, no history of jaundice and ascites, no history of chronic headache, seizures and loss of consciousness, no history of lower abdominal pain or distension, no history of lump in the contralateral breast. Past history. No history of past surgery for benign breast lump, no history of previous childhood radiation, not a known case of diabetics, hypertension, TB and epilepsy. No history of chronic drug intake. Personal history, mixed diet, normal bowel and bladder, normal sleep, no history of substance abuse. Family history, no other family members have similar illness. Treatment history, no treatment is taken. Menstrual history, age at menarche 13 years, age at menopause is 51 years. Marital history, age at marriage is 24 years, non-consanguineous marriage, age at first childbirth is 27 years, breastfeed for 6 months. Summary. 68-year-old female, Mrs. Kasturi, came to OPD with chief complaint of painless lump in the left breast for past 2 months, which is insidious in onset and gradually increased to attain present size.
General examination. Patient was examined after informed consent in the adequate light and exposure with adequate privacy. Patient was comfortable, cooperative, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy, except the left axillary lymph node were palpable, no edema, height is 160 cm and weight is 67 kg, BMI is 26.2 kg per meter square. Vitals, pulse is 80 beats per minute, regular, normal volume, no specific character and recorded in the left axillary artery. Blood pressure is 110/80 mmHg recorded on the left upper arm. Respiratory rate is 19 breaths per minute and temperature is afebrile. Breast examination. Inspection after getting consent from the patient with adequate exposure from the neck to waist. Examine maintaining adequate privacy. Inspection done on the sitting position with arms by side, then arms raised above the head, arms pressed over the waist and leaning forward, and then on supine position. Inspection with arms by side. Left breast is slightly higher than the right breast. Left breast is larger than the right breast. A lump is seen in the upper outer quadrant of left breast, around 7 x 6 cm in size, irregular in shape. Skin over the lump is normal. Surface appears to be smooth, no ulceration, no scars or sinuses, no dilated veins, no dimpling, tethering, puckering or purely orange appearance. Left nipple and areola complex. Nipple is deviated towards the lump. Circumferential type of nipple retraction is seen. No discharge from the nipple, no visible swelling in the axilla and the supraclavicular fossa. Arm, thorax and neck appears to be normal. Inspection with arms raised above the head. Left nipple is higher than the right nipple. Inspection by pressing the hands on the hip. No change in the lump size. Inspection on leaning forward. Left breast is larger than the right breast and falls equally. Palpation. All inspectory findings were confirmed by palpation. Left breast, no warmth and tenderness over the lump. A single lump of size 7 x 6 cm present in the upper outer quadrant of breast, which is irregular in shape, well-defined margin and hard in consistency. No discharge from the nipple. Fixity to the skin. Skin is pinchable over the lump and skin was made to slide over the lump. Fixity to the breast tissue. Lump moves along with the breast tissue. Fixity to the muscle. Lump is not fixed to the muscle. Examination of left axilla. Axillary group. Anterior group, single node of 2 x 2 cm, mobile, hard in consistency, non-tender group is palpable. Supraclavicular nodes are not palpable. Percussion over the parasternal area was resonant. Examination of opposite breast and axilla is normal and supraclavicular fossa is free. Systemic examination per abdomen. The abdomen moves with respiration, soft, non-tender, no liver enlargement or palpable lump, no free fluids, respiratory system, bilateral normal vesicular breath sounds heard, no added sounds, cardiovascular system, S1, S2 heard and no murmur, central nervous system, alert and conscious, no focal neurological deficit, spine, cranium, ribs were normal.
Summary: a 68-year-old postmenopausal lady with painless progressive left breast lump for 2 years, past 2 years with recent onset of nipple retraction. On examination, there's a 7 cross 6 centimeter non-tender hard lump involving the upper outer quadrant of the left breast, which moves along with the breast tissue, and circumferential nipple retraction is seen. Single anterior group of axillary lymph node of 2 into 2 centimeter size is palpable. Diagnosis: locally advanced breast malignancy of the left breast with no clinical evidence of metastasis. TNM staging is T3N1N0, stage 3A.
Very nice presentation. You have covered almost all areas, and when you take a case in a breast, a diagnosis of a benign disease should be your last diagnosis. So definitely think about malignancy only. And my first question will be, starting from the history, what are your points in favor of your diagnosis?
Age, it is 68 years old. So malignancy is common after the age of 40. Then a painless lump. Usually painless lump is seen in malignancy. Then short duration and progressive in size recently.
Is she a male or a female?
Female.
So female gender itself.
Female gender is risk factor for carcinoma.
Yes. Can you get male cancers, male breast cancers?
Yes, sir.
What is the difference between a male breast cancer and a female breast cancer?
Male breast cancer. Bad prognosis is seen in male breast cancer.
Very good.
Then
Anything else? I don't know whether it is your...
gynecomastia.
No, gynecomastia is a benign condition in male.
BRCA2 mutation.
BRCA2 mutation. Very good. Yes. So continue with your
Then
points.
Upper outer quadrant,
Yeah.
where the most of the terminal tubular units is seen. Then we rule out the metastasis, like back pain for bony metastasis.
Is it in favor of malignancy?
No, it just rule out metastasis.
So in the history itself,
Yes, sir.
is there anything else? Yes,
Retraction of nipple.
marital status, menstrual status. Any history of radiation, did you ask?
Yes, sir. No history of radiation in childhood. And then early menarche, she attended menarche around the age of 13. Then
What is the early menarche?
less than 12 years.
Yes.
Then menopause, around 50 years. Then first childbirth is around 27 years. Then
Is it important?
yes, sir. Late first child after 35 years increases the risk factor for breast malignancy. Then
What is that? Why is that important?
estrogen
First childbirth.
exposure, unopposed exposure of estrogen.
Unopposed
Exposure
estrogen
of-
exposure. Yes. Palpation part, lump. What is the size of the lump?
7 cross 6 centimeter.
7 cross 6. What about fixity, consistency?
Hard in consistency.
All through hard. Okay. Mobility?
Mobility, it is mobile along with the breast tissue but not fixed to any underlying muscles. Breast tissue, first falling forward. ಅದು chest wall fixity. Move the lump.
See, you have skin fixity, breast tissue fixity, pectoral fixity, chest wall fixity, isn't it? These are the fixities. Skin you have already pinched, slide, etc. Then the parenchyma of the breast. How will you check for fixity of the parenchyma of the breast?
Lift the breast above.
Anyway, we will go into the discussion.
So shall I take off from where Thomas sir said? Suppose you have a washing line, and a piece of cloth is hanging, and you want to imagine this much size stuck onto the piece of cloth. Wind blows, both will move together, no? So you want to actually know whether this thing which is stuck onto the piece of cloth is having independent mobility. What will you do? You will first fix the
Fix
cloth
the
and then try
breast
to
tissue
move, no?
and then
So you will first fix the breast tissue.
tissue and
How
then-
can you fix the breast tissue? So you actually, when you move the breast lump, the breast together with the lump moves, just like the thing in the cloth. Okay. So you first fix the breast tissue and then try to move the lump. How can you fix the breast tissue?
Raising the arm above the head.
So since being an academic session,
Breast tissue will be fixed on.
so you first fix the breast tissue against the chest wall like this. If this is the breast, you fix the breast tissue and then catch hold of the lump and you try to move. So that the breast tissue is fixed. Okay. And then you try to move. Suppose it is a fibroadenoma,
It moves
it moves.
independent of
But
breast
being
tissue.
a malignancy, it will get attached to the breast
Breast
tissue
tissue.
and it will not move.
7 cross 6 centimeters.
7.
Around
What was the size when it was palpated? But if it is a large breast, only a part of the lump will be seen. When you palpate, actually it will be much bigger. So the breast, if it is large, if it is very thin and the patient is emaciated, then both the inspection findings and the palpatory findings will be the same. Otherwise, you can just imagine, no, with common sense, that within the breast, if something is lying, only a small part will be visible. Okay, so I genuinely doubt the veracity of your concurring inspection and palpatory findings. Okay.
About the size in inspection, it appears to be enlarged, or there is a fullness, you can say. But since it is a LABC, you can see the swelling, but as sir told, you can it cannot be the same. Okay.
Now, in which quadrant was it lying?
upper outer quadrant.
Can you give an explanation? Where is it common in the breast?
Upper outer quadrant.
Any explanation for that?
Because more glandular tissue is more in upper outer quadrant.
The major part of the glandular tissue lies there. And in inspection, you said something about tethering. What is that tethering?
Tethering is when the malignancy involved Ashley Cooper's ligament.
How will you demonstrate that? You said in inspection you could see tethering.
Move the lump.
Movement is palpation.
Inspection. Raise the arm above the head. Dimpling. If it is tethered, dimpling of skin can be seen.
My dear, tethering is a palpatory thing. I don't know how you put it into the inspection. What is tethering actually?
Involvement of Ashes Cooper's
That is pathology. Clinically,
pulling of skin into the lump.
when pulling of the skin outwardly will produce, as Thomas sir said in his presentation, outwardly it will produce a dimpling or a puckering. That is the thing in inspection. In palpation, it is tethering.
Moving the lump in opposite direction.
See, when the lump is moved, suppose there is a dimpling, that dimpling gets aggravated. Suppose there is no dimpling, if you move the lump, a dimpling now appears. That is also a tethering. Or a puckering gets aggravated. That is also tethering. So tethering is it's a palpatory finding, not a inspection.
Like
finding.
you see in lipoma, you push the swelling to one side, the lobulations will be more prominent, no? The same way.
No, even though in palpation, students often say that the inspection findings are confirmed. I think it is not proper, because in inspection you can, one of the findings is the findings of the skin, for skin color. You can't confirm that skin color in palpation, can you? You close your eyes and you palpate, can you say this is red, this is violet? No, you can't. So it's always better that information, the one thing I said earlier on, that is the size can differ. And the extent can also differ. Extent means some lump arising in the upper outer quadrant, extending into the upper inner quadrant. That you will get it only in palpation. So you can't confirm that. Okay. And then you said the lump is not fixed to the underlying muscle. That is your inference. In your presentation, it should be the finding which has to come out. How did you do that? Fixity to the muscle. And which muscle is it?
Pectoralis major. Ask the patient to press the arms against the waist and move
By
the
the way, just one thing. Which is the most ideal position to examine the breast lump?
semi-recommend position.
Exactly. If that is not possible, what is the effective compromise?
Supine position.
Exactly. Yes, now you can carry on.
Then move the lump along the direction of muscle fibers and then to the right angle. If it is fixed, then the complete restriction of mobility along the
No, that is the finding that has to come out. On contracting the muscle, the swelling is mobile in vertical as well as in horizontal directions. And now the examiner will ask you what your inference is, and now you have to say that it is not fixed to the breast tissue. How can you confirm there is chest wall fixity?
on leaning forward. If it is not fixed, breast.
If it is suppose the lump is fixed.
Breast does not fall equally.
Any other thing before that? Before asking the patient to lean forward, any other finding can say that the lump is fixed to the chest wall?
Restriction of movement with the muscle.
What is chest wall?
Ribs, intercostal muscles.
Yes. And over that you find the muscle, no? How can you know it's fixed to the chest wall? For example, I'll take you back to that particular hanging cloth. And this is the wall there. If it is the cloth, imagine that is muscle and the lump is all fixed to the chest wall. What will be your finding if it is fixed to this wall? You try to move, it will be?
Not mobile.
It will be immobile. At the outset itself, totally immobile. Totally immobile. That is chest wall fixity.
You said chest wall fixity is to the intercostal muscles, isn't it? And the rib cage. Any muscles fixity?
Serratus anterior.
Serratus. How do you check?
Ask the patient to pull against the wall and push against the wall. Then move the lump along the direction of muscle fibers.
Okay.
If it is fixed, it is immobile.
Okay. It will be immobile irrespective of any of the muscle contractions or any augmenting test you do. From the beginning itself it will be immobile, chest wall. Your staging is
T3N1 and M0, stage 3A.
T3N1. N1 is
Ipsilateral axillary node is palpable and it's mobile,
mobile, ipsilateral.
not fixed. Axillary,
Mobile means it is fixed. It is not fixed.
not fixed.
So, ipsilateral axillary lymph node, mobile axillary lymph node. How do you stage a supraclavicular lymph node involvement?
It will go for N3C. Stage 3C. Metastasis.
If, yeah.
Ipsilateral supraclavicular is N3. If it is a contralateral, it becomes
M1.
M1. Okay.
Yeah. Suppose there is a lesion in the other breast. When you examine the contralateral, you have examined the contralateral breast. That is, I am happy about it. Suppose you find a lump in the contralateral breast. And some findings of malignancy. How do you exclude whether it is from the breast? Can a breast lump or a malignancy in one breast spread to the other breast?
Yes, it can.
It can, isn't it? And also it can be another primary. How can you distinguish between these two?
Using Chowdhury-Millis criteria.
Very good. Yes.
There are 4 criteria.
Yeah.
The first one is there should be a carcinoma in situ present on that is a primary, and if it is present, it should be different in the histological differentiation than the first breast. And the third is it should be a higher differentiation than the first, and if there is no histological differentiation, then there should be no evidence of distant spread from the contralateral breast.
Yes, very good. Okay, so this is stage 3A and it is a
Locally advanced breast
locally
cancer.
advanced LABC. How do you proceed?
With a triple assessment. Triple assessment consists of clinical assessment, radiological imaging, and pathological tissue diagnosis.
So what is the age of this patient?
68.
So what imaging will you do?
USG. Sorry, mammogram.
Younger age group you do?
Younger age group we do USG because of dense breast tissues.
5% dense breast. You can get maybe mistaken reports you can get. So in older age group, you will prefer ultrasound. No, mammogram, isn't it?
Yes, sir.
So mammography. What are the advantages of mammography?
We can
And also disadvantage.
mammography will tell there will be it will show the architectural distortion, microcalcification.
How do you report mammogram?
Birad scoring.
Birad scoring, yes. How many scores are there?
Total 6 are there.
No, I won't go beyond that. Okay.
Less than 3 will be benign. There is no clinical significance.
Let's stop there. So, mammogram. There's one advantage of mammogram. Can you tell me what an advantage of mammogram?
Indication and advantage. Huh? When will you prepare?
Screening purpose and diagnostic.
Yeah. It's in screening
Screening
purpose
purpose.
and also the opposite breast, contralateral, it will exclude a malignancy in the other breast, isn't it? Okay.
Indication of MRI? Good.
Implants.
The presence of implants. Good.
Any other investigations?
Baseline investigations like
You prefer FNAC in this case or true cut biopsy in this case?
true cut biopsy.
Why?
Because it helps in differentiating if it is an in situ or an invasive carcinoma, and also receptor studies can be done in case of this. FNAC doesn't.
FNAC definitely tells you whether it is malignancy or not. That is what you want in primary. Why do you prefer true cut in this case? I agree with you, you have to do true cut in this case. But is it diagnostic?
Receptor studies can
No,
be
is it for diagnosis or some other thing?
treatment purpose, prognosis, and for deciding their treatment.
What treatment?
Hormonal therapy,
For LABC, you prefer first what therapy?
chemo, neoadjuvant chemotherapy.
That's it.
So that is why, because in this case, your treatment will be maybe neoadjuvant chemotherapy. We haven't decided it upon, but probably it will be a neoadjuvant chemotherapy. So before chemotherapy, giving the first dose of chemotherapy, you have to get a receptor status study. Why?
It responds well to.
Maybe the chemotherapy can alter this. Maybe can alter this receptor status. So initially you have to get a receptor status to plan a hormonal therapy later on. So there is always FNAC is superior to true cut for diagnostic purpose. What is the advantage of FNAC
Non-invasive.
over true cut? If you don't answer, they will answer.
It's it can be repeated at least 2 times, and it is cheaper, and
It is easy to conduct. You can do it in the bedside.
And done in a OP procedure.
Yeah.
No need for anesthesia. Yeah, 5 needle, 26. It won't cause any pain. So that's the advantage of FNAC.
You can repeat it. You can repeat it in many angles.
Multiple.
The report will be ready within 1 day or maximum 2 days, isn't it? So diagnostic purposes. But here, as you said, true cut biopsy is indicated because of the treatment plan. Okay. Right.
See, you said it is a carcinoma breast. How did you come to the diagnosis that it is carcinoma?
because of the age, the gender, and also the shorter duration, progressive increase of size, and there is circumferential nipple retraction, then the risk,
Finding.
and also the
What about the finding?
it is not fixed to the chest wall, and it moves freely. Sorry, it doesn't move freely.
Any characteristics coming out of the lump?
It is irregular.
What is irregular?
The lump
I
margin.
mean the margins. What about the surface? Does the surface contribute to your diagnosis? What about the consistency?
Hard in consistency.
Does that contribute to the diagnosis?
Yes.
Is it LABC or EBC? What made you think it is LABC?
More than 5 centimeter. With
What is the basic difference between EBC and LABC? Why should there be a distinction like a EBC and LABC? What is the intention? What is the purpose?
We directly take them for surgical.
Huh?
We don't give
know the early breast cancer and the locally advanced breast cancer.
neoadjuvant chemotherapy is not given.
Modality as and the surgical plan. Treating but no.
So in early breast carcinoma, the concept is that the disease is confined to the breast. It does not spread to other parts of the body. If at all it has spread, it is there is a tiny risk. But in LABC, the concept is that the disease has already left the breast forever. Okay, only thing is that your clinical examination or your investigations are not revealing the metastasis. We know for sure that the disease has left the breast. That is why LABC. So with that concept in mind, what investigations will you order in EBC? What investigations will you order in LABC? What are the investigations? You know, any malignancy is investigated in this fashion. 1, to prove the diagnosis. 2, investigations to assess the extent of this local spread. And 3, the investigations to assess metastatic spread. Okay. Breast being a superficial organ, you forget about the local extent. We can palpate it and find out. So you have confirmed the diagnosis with your true cut. Now you are into your metastatic workup. What difference is there in EBC and LABC in metastatic workup? Okay.
CT test for lung, then X-ray system for chest, skull, then numbosacral region.
What investigation will you do?
Bone scan,
Exactly. So these are the 3 investigations. In EBC, what investigations will you do to know the metastasis? You will do it or you will not do it? You can or it should be done. Should be done. When science says that metastasis is very minimal and the detection rate is very less, still you want to do that?
In this case, it's not indicated. Suppose if the age is premenopausal, cancer.
Okay, if that is the concept of LABC, what is the treatment of LABC? A disease which has spread to other parts of the body already. We know for sure it has spread. What is the treatment?
multimodality approach.
What multimodality?
Starts with neoadjuvant chemotherapy.
Yes, you start off systemic therapy because it is a systemic disease. You start off. And what is the advantage of starting off and why should a surgery be done?
Downsizing the tumor,
What is the purpose of
making
doing
it
a surgery?
operable.
Surgery is done, no?
Okay.
In this case, surgery is indicated or not?
Yes.
Yes, what surgery is done? Does it cure the disease?
No.
Does it cure the disease?
Only surgery will cure, sir is asking.
In EBC, what is the purpose of doing surgery? The intention of, is not the purpose, the intention. Huh?
It's curable.
The intention is to cure. We don't know whether it will cure or not. But can the same be applied to LABC? Doing this surgery, will it cure? No. Then why are we doing the surgery? Improve the quality of life. Can you be more specific? You are right. No, you can't call it palliative.
This is curative. MRM is a curative.
You said the quality of life can be improved. By what means? Lifetime will not be prolonged. What is that, my dear? Ulceration, very good. It can ulcerate and fungate and smell like anything, and her social life is gone. Any other thing? Oh, well, metastasis is already gone because it is LABC. Only investigations are not finding it out. See, it can erode into the vessels. For example, intercostal vessels. If it is in the axilla, it can erode into the axillary vein and cause torrential bleeding. And that bleeding can cause death. So somebody who is destined to live for some more years is going to die much before that. That is the reason why surgery is done. Okay.
I think there is only time for a few more questions. Your patient is a postmenopausal LABC patient. You have done modified radical mastectomy, and the status has come as ERPR positive. What hormonal treatment will you give? What is tamoxifen?
It's a selective estrogen receptor modulator.
Why is it called selective estrogen receptor modulator?
It acts only on the breast tissue. Estrogen receptor is present in the breast tissue.
Not fully correct. It acts on the breast tissue. What is the other name for tamoxifen? The previous name was something else. It is anti-estrogen action. It has an anti-estrogen action. Estrogen always promotes malignancy. So anti-estrogen action. So it was known as anti-estrogen. But the reason name is SERM. Because it has anti-estrogen action on breast and estrogenic action on
Uterus.
so what are the advantages of tamoxifen?
It decreases the action of estrogen on breast.
It is anti-estrogen action.
Okay.
Yes.
And
Anything related to the metastasis? Bony metastasis? What is the dosage, ma? Dosage of tamoxifen?
10 mg BD for 5 years.
Now they are saying 10 years.
10 years.
So it prevents a recurrence in the other breast. Takes care of the other breast. And there are other advantages. It has estrogen action on other tissues of the body. So what are all females are protected of cardiovascular, bone resorption, etc. until the reproductive age group. So all these advantages you will get with tamoxifen because of the estrogenic action on extramammary tissues. Okay.
What thing you have to screen when they are taking tamoxifen for long period in a female?
Endometrium.
So you have to follow the patient.
To prevent CA endometrium.
Very good, very good.
Okay, I think it is time. So we will wind up. Very good presentation, and they are updated also. Okay, thank you very much.